Welcome to the workshop, Graft-versus-Host Disease, Gastrointestinal Tract. My name is Michaela O'Brien, and I will be your moderator for this workshop. It's my pleasure today to introduce today's speaker, Dr. William Clark. Dr. Clark is an Associate Director of Medicine in the Division of Hematology-Oncology at the Virginia Commonwealth University. He is also the Director of the CAR T-cell therapy at Massey Comprehensive Cancer Center. Dr. Clark's research focuses on identifying biomarkers to predict graft-versus-host disease after transplant. He participates in clinical trials studying ways to prevent and treat allogeneic stem cell transplant complications, focusing primarily on acute and chronic GVHD. Please join me in welcoming Dr. Clark.
Hi, good afternoon. My name is Dr. Bill Clark from VCU in Richmond, Virginia. Thank you so much to BMT InfoNet. I'm honored to be here today and to share information with patients and loved ones of patients and family members about acute GVHD of the gut. I do love the Celebrating a Second Chance at Life Survivorship Symposium because what we do here is we cure cancers that would not otherwise be curable. And so it really is giving someone a second life, a second chance at life. Okay, so learning objectives, we're going to do a brief overview of allogeneic stem cell transplant. This is a donor transplant. Risk factors for acute graft-versus-host disease, specifically related to the gut, the stomach, and colon. A little bit of basic colon biology and the gut microbiome, which is becoming even more important. Diagnosis and assessing acute GVHD, and then prevention and treatment of acute GVHD, mostly focused on GVHD of the intestinal tract. So back to the basics here. This is a diagram of your stem cells. These are hematopoietic stem cells. They are blood stem cells that live in your bone marrow. They're very unique cells. When we talk about stem cells, it means the cells have a special property where they can make more of themselves. So these cells can regenerate and make blood for your entire lifetime. These platelets can do lots of different things, including making your platelets for blood clotting, your red blood cells for carrying oxygen, and your white blood cells to help fight infection. There's a dozen or so types of white blood cells, but the two most important are the T cells. The T cells are the ones that are responsible for cell-to-cell killing. They're also really critical for distinguishing things that should be in your body versus things that should not be in your body. So, your normal cells on your skin or your eyes versus COVID or flu or a staph infection. And then the other cells, the one in the orange, those are the B cells. Those are also very special cells of the immune system. They make antibodies. You may remember back at the beginning of COVID, people that survived COVID, we took their antibodies and then gave them to people that were sick in the ICU to help get them through their COVID. So the immune system, so generally what we do with allogeneic stem cell transplant is we give patients high doses of chemotherapy to kill more of their cancer. And for moving on, I'll just say leukemia to cover most everything. But I know there's more than one diagnosis for transplant. And the side effect, though, is we kill the stem cells. So we can rebuild the blood with putting stem cells in the patient with from another person. They can make all the blood and red blood cells, but it comes with new T cells. And those new T cells, they're going to go into the patient's body and look around how different it looks from the body it came from. And it may react to that body. And the amount that it reacts to that body is the amount of graft-versus-host disease that patient will have. However, the T cells can learn in your body over time. And the plan, if things go well, is people will not need immune suppression 6 to 12 months after transplant, as those new T cells have learned and adjusted to your body. So this is the journey that our patients have here. We see them in the first initial consult. We do an evaluation to make sure that their leukemia is appropriate for transplant, that they're fit enough for transplant. We test the heart, lungs, liver, and kidneys. Exercise of the person going through transplant is really important. At that first time, we do HLA typing. HLA is a gene you get from your parents. You get 6 from your mom and 6 from your dad for a total of 12, and 8 of those are important. So we look for an 8 out of 8 for a full match donor. And we look at sibling donors. People have about a 25% chance of matching with their siblings. Unrelated donors, depending on your race and ethnicity, that can range from 40 to 80% chance of finding a match there. And then also with mismatched donors. Given all the donors that we can look at now, 99.7% of people find donors. When we choose donors, we look at the HLA typing, we look at age, gender of the donor versus the patient, blood type, and what source of stem cells are we going to use. Are we going to use bone marrow, where we do bone marrow harvest, or peripheral blood, where we collect cells through an apheresis machine like the Red Cross does. Both of those can have different impacts on risk of acute graft-versus-host disease. So the next part is they've been through all their testing and we're ready to discuss the plan. This is a very important time because all the choices we're making now can have impact on risk of leukemia returning, ongoing long-term remissions, risk of graft-versus-host disease, and risk of infection. So first, we talk about the chemotherapy plan. We have relatively 3 levels of chemotherapy. This can be given with or without radiation. We use full intensity therapy, reduced intensity, and very reduced intensity. Full intensity comes with a slight reduction in risk of relapse of the leukemia, but comes with more side effects of the chemotherapy. More nausea and vomiting, more problems with the liver, severe low blood counts, risk of infection, and increased risk of graft-versus-host disease. Reduced intensity and very reduced intensity comes with less damage to the body, but maybe a slight increased risk of the cancer coming back. Then we want to talk about graft-versus-host disease. How do we try to prevent GVHD? And we're coming up with new plans to prevent GVHD better and better over time. The goals of all this part of the process is we want to decrease the risk of relapse as much as possible, while also decreasing the risk of graft-versus-host disease, managing the risk of infection, so that at the end of the day, we improve people's chance of surviving with a good quality of life after transplant. So the patient comes into the hospital. Sometimes this can be done in the outpatient setting. They receive 4 to 7 days of chemotherapy with or without total body radiation. Then they have their stem cell transplant, day +0. It's a stem cell infusion. It's like a blood transfusion. It happens right in the hospital bed. There's no other surgery involved, and it's a very exciting day for everybody. It's your new birthday, your second chance at life. And then the most standard way that we prevent graft-versus-host disease starts after transplant. Day 3 and 4, we give doses of IV chemotherapy called Cytoxan. Cytoxan is really good at killing T cells that are growing too quickly. So the T cells that are going to react to the patient's body are going to grow the fastest. And the Cytoxan kills them off with 2 days of chemotherapy. The T cells that are not going to react as much to the person, they live on, and over the next several months will rebuild the immune system. We also start other immune suppression at day +5. The main one we give here is called tacrolimus or sirolimus, and that usually goes for 2 to 6 months depending on the situation. People then are in the hospital for 2 to 4 weeks or in clinic during the intense part of their transplant, and at the end they all get to want to ring the bell when they leave the hospital and go down the elevator. This shows how we've been making improvements in survival of transplant year to year. You can see in 2001, we had about a 5-year survival of 40%. That's now up to, and higher than, I would say, 60% on average for transplant. So all these little things that we're talking about donor selection, using different chemotherapy, changing the GVHD prevention and the antibiotics to prevent infection, all of these things are making improvements in outcomes in transplant. I did want to talk a little bit about HLA. HLA is how we find donors, and it's how the immune system tells whether something is from yourself or from somewhere else. For example, people with kidney transplants, the HLA doesn't match, so the person's immune system would reject the kidney. That's a foreign object in their body. They have to be on immune suppression the rest of their lives. With stem cell transplant, the new T cells can learn the HLA and not overreact to it so that you don't have to be on immune suppression the rest of your life. When we're looking at HLA and donors, we're looking for mostly a full match. That would be an 8 out of 8 match. But you can see here, since we've been using post-transplant Cytoxan, whether you have a 8 out of 8 match or a 7/8 out of 8 match, the survival is the same. And then the GVHD survival is the same. That's the graph on the left. The graph on the right shows that if you have a 7 out of 8 mismatch or a 4 out of 8 mismatch, survival is the same. So really, HLA is not the most important factor anymore in choosing donors for transplant. Probably age is the most important, and this makes transplant more available to all people. There used to be a lot of people we would have to turn away because they didn't have a good match. Now 99.7% of people have a good match. So on to acute graft-versus-host disease of the gastrointestinal tract or of the gut. And this is caused by the new donor cells attacking the patient's cells that line the colon. This usually happens in the first 100 days. Average onset for acute graft-versus-host disease is 2 to 7 weeks after transplant, but it can happen at any time, even 180 days afterwards in the right setting. Acute GVHD is not defined by the timing, but by the symptoms. It's a red rash, liver damage, diarrhea. People can have persistent nausea, vomiting, or loss of appetite, or weight loss. The incidence of acute graft-versus-host disease of the gut are 30 to 50%. Most of those cases are mild. Moderate to severe cases are less than 10%. Over time, with improvements in immune suppression, we have made improvements in the amount of severe acute GVHD. Really, when you think about mild, moderate, severe, mild, severe has little impact on the outcome of the patients. I'm more concerned about the patients with severe acute GVHD. You can see over the last 20 years, we made huge improvements in the incidence of severe acute GVHD. 20 years ago, 20% of people had acute GVHD. 10 years ago, 15%. And with the most recent studies, about 6% have severe acute GVHD. This is really important because people with severe acute GVHD, only 5 to 20% of people would survive that scenario. So these improvements of preventing severe acute GVHD are critical. There's also chronic GVHD. This usually occurs 4 to 12 months after transplant, around the time that we're usually removing immune suppression from people. The symptoms of this are dry eyes, dry mouth, and dry skin, but it can affect any organ, including the lungs. It's like an autoimmune disorder like lupus or Sjogren's, which is dry eyes, and we treat that with more immune suppression. We've also had improvements in chronic graft-versus-host disease outcomes over the last several years. In 2015, about 35% of people had chronic graft-versus-host disease to currently about 21%. And this would be more in like the moderate to severe range. Chronic graft-versus-host disease does come with a benefit though. People with chronic graft-versus-host disease have less relapse, which means they have more graft versus leukemia effect. That's the new immune system fighting and killing the cancer and providing surveillance so that the cancer will never come back. You don't have to have chronic graft-versus-host disease to remain in remission though. So how do we diagnose acute graft-versus-host disease? GVHD is a clinical diagnosis. It's not based on biopsies. It's based on the symptoms. A red rash, usually a raised red rash, we call a maculopapular rash. Diarrhea, damage to the liver based on an increased bilirubin. Increased bilirubin turns people's eyes yellow. It's called jaundice. Persistent nausea and vomiting, more than 10% weight loss, decreased appetite. Biopsies are not required, but if possible, we do biopsies. Skin biopsies are pretty easy to do if needed. Colon biopsies we try to do on a regular basis, especially for people with severe acute GVHD. We want to make sure that it's graft-versus-host disease, but even more importantly, we want to make sure that it's not an infection and we're just misdiagnosing it. Liver biopsies are usually not practical during this time, but can be done in the right setting. The risk factors that affect acute GVHD of the gut. First is the intensity of the chemotherapy and radiation before transplant. The full intensity transplants cause more damage to the cells that line the gut. Those cells, when they're undergoing damage, release chemicals that stimulate the immune system to say, hey, something is going on wrong here, and those new immune cells come in to repair the damage. But these new T cells that come in to repair the damage, they're not ready for it yet. They don't know how to behave. They're like a bunch of minions running around with their heads chopped off. And even if they can help repair the damage, they don't know when to stop overreacting to the gut cells. And so they damage the gut cells as they're trying to heal them. Other risk factors for GVHD, we talked about HLA matching, but that plays less of a role now. Risk of infections. One infection that can increase your risk of graft-versus-host disease is Clostridium difficile, or C. diff, which is a common infection in transplant survivors. And that can increase the GVHD risk because of the inflammation in the colon. Other infections, such as norovirus, and things like that, can also increase the risk of graft-versus-host disease. And then damage to the gut microbiome. Your gut microbiome is an amazing, complex, living organism that has positive interactions with your own gut as a feedback loop. Your gut helps support the gut microbiome helps support your gut, and without one or the other, things don't go well. So the gut microbiome is very important to have a healthy gut microbiome. So we're going to talk a little bit more how we assess and grade graft-versus-host disease of the gut. There are two other grading systems for liver and for skin, but we're going to focus just on gut here, mostly with the lower GI tract. So most people's stool output should be about 200 to 300 milliliters a day. So stage 0 would be less than 500 milliliters. This is half a quart, 16 ounces. Stage 1 would be persistent nausea, or a half a quart to a quart of diarrhea, a liter of diarrhea. And then when we're getting to the moderate to severe forms, grade 2, 3, and 4, you would have a liter to over a liter and a half to 2 liters of diarrhea. I've even seen up to 4 liters or 4 quarts of diarrhea. And then grade 4, the most severe form, is with severe abdominal symptoms, abdominal cramping and pain. So what is so then when people have that, let's say they have a liter and a half of diarrhea, we would order a colonoscopy. Usually it's not the full colonoscopy, but a shorter version of that. And you can see here on the left is a normal colon. The layers that line the cell are tan. They don't look inflamed. You can see easily through them, and you can see the blood vessels coursing through them. On the right, you can see chronic what acute GVHD of the colon looks like. All of that texture and how the light reflects off of it is gone. It looks like everything has been obliterated. It's like a moon landscape almost, and you can even see ulcers here where the T cells are attacking the colon. All the redness is related to graft-versus-host disease. It looks like there's a sunburn there, but it's inside the colon. So then we take a biopsy. The picture on the left is a normal colon, and you can see these little fingers that go into the wall of the colon. Those are called the crypts of the gut, and that's where all the action happens. The stem cells that make the gut, that make the cells that line the gut are there. These special cells called goblet cells that make the mucus in the gut and keep the gut healthy, they're all there. But if you look on the right, that pattern and landscape of a normal gut has been completely obliterated. It's like a bomb has gone off in the gut, and all of the normal architecture is gone. So this is a picture to better look at what those gut crypts look like. And you can see there are these little indentations that go in like a U-shaped pattern. At the bottom of the U, there's a very important cell called the gut stem cell. And these are the cells that give rise to all the cells that make your gut. Then the other one, these blue cells, are called goblet cells. And they make the mucus that lines your gut and protects it from the outside world. Then there's a healthy gut microbiome. You can see the bacterium. There's a dozen different colors there. They're all doing different jobs. They're making butyrate to support the health of the goblet cells. Butyrate is a critical fatty acid that helps the gut heal from damage and also to support gut health. But in graft-versus-host disease, the new immune system has killed some of these critical cells. You can see the goblet cells are dying, so there's no mucus. The gut microbiome is very limited. 10% of the microbacteria that should be there are there, and they're not producing the good part that helps support the gut health. The gut stem cells are damaged, so the gut can't repair and heal itself. So there's a lot of issues going on during this time with damage to the gut from the colon that the colon's having a hard time dealing with. So how do we manage acute GVHD? Key strategy here, acute GVHD doesn't come with the benefit of graft versus leukemia effect. So prevention is key. So that is all the pre-transplant considerations. That would be a healthy gut microbiome, what kind of graft versus host disease prophylaxis we're going to do, what kind of chemotherapy we're going to give, how much damage is going to be done to the colon. And then treatments. We're talking about first-line therapy in a bit, second-line therapy, and then when people are going through, mostly I'm going to be talking about severe acute GVHD, a lot of supportive care comes into play to get people through this, not just active treatment with medications. So I want to talk a little bit most about the gut microbiome. It's been rising in interest over the last decade or so. The gut microbiome is a diverse community of trillions of bacteria, virus, and fungus that are essential for life. You can equate the gut microbiome to the Amazon rainforest or the rainforest in Costa Rica, where there's the most diversity on Earth of different living organisms. And it works with your gut and supports life. And without the gut microbiome, human life would not be what it is. Transplant patients have a less diverse gut microbiome. That's because they've had lots of chemotherapy. We give people lots of antibiotics to prevent and treat infections. And by the time people with leukemia or MDS get to transplant, they've been through lots of chemotherapy, they've had nausea, nutritional status has varied during this time, and sometimes they have a limited diet, which limits the gut microbiome. Okay, well, this picture is a little bit complicated. Honestly, it's very difficult for me to interpret it as well, but try to look at it with simple eyes. Each color on the graph represents a different microbe in the gut microbiome. And when you have more colors on the graph, that means there's more diversity in the gut microbiome. On the left side, you can see the normal gut. People that are not transplant patients, I should say, not normal. And you can see there's a lot of different colors for the normal gut microbiome. But on the transplant side, there's very limited. So one's beautiful, has all these great colors, very diverse. It's like the Amazon rainforest. But, the transplant patients, it's like Death Valley. There's some things there, but not many things can survive what they've been through. And this puts people at risk. So how can we support the gut microbiome? We can use probiotics. Probiotics are living bacteria that restore the healthy gut microbiome. This can be complicated as we don't know what living bacteria we should give to fully restore the gut microbiome. Most of the pills you take over the counter only have 1 or 4 or a dozen different bacteria, not the hundreds of different bacteria that you would need or thousands. So prebiotics is what people are looking at. These are nutrients that are necessary for the healthy gut microbiome. So, for example, one species of bacteria called Blautia helps protect the gut microbiome, and people that have Blautia have less risk of acute graft-versus-host disease. So Blautia is very critical for making butyrate for gut health and for mucus production for the goblet cells. So how can we support the Blautia? So one way is to increase fiber, particularly fermentable fiber. You get that through whole grains, beans, vegetables, prebiotic foods such as garlic and onions. And at University of Michigan, they've actually done a study where they found that the cells need butyrate to help support gut health. And they looked around for the best place they could find the highest amount of butyrate, and they found resistant potato starch This is like Sam's Red Mill. You can get it at Whole Foods, Bob's Red Mill, potato starch. And they gave it to patients after transplant with an improved, a decreased risk of acute graft-versus-host disease of the gut. And this study is potentially moving forward with the Bone Marrow Transplant Clinical Trials Network and a national clinical trial to help reduce graft-versus-host disease. What they would do is they'd take a small cup of the potato starch and add water, and the patients would have to drink it raw. I'm sure that wasn't very tasty, but these are some of the things we can do to help support the gut health. Other ways to support gut health would be antibiotic stewardship. This means that we should be thinking about the antibiotics we're giving people every single day. Certainly, transplant can't be done with a lot of infection prevention. But when people have fevers, we should minimize the amount of antibiotics they're on, keep them for the shortest period of time, and make them as most specific to the infection as we can to help preserve the gut microbiome. Eating a diverse diet. Generally for diets, I recommend a healthy, well-balanced diet. And as per the USDA guidelines, that would be lots of plants, fruits, and vegetables, lots of fiber with, as you go up the chart, less meats and, oils and fats and sugars at the smaller amount. Improved sleep and exercise routines can improve the gut microbiome. There's a lot of data that says that sleep patterns, anxiety, and depression are linked to healthy gut microbiomes. And then fecal transplant is the best way to replace the microbiome in the gut because it has all the bacteria, fungus, and viruses that are necessary, but this comes with risks. Where we can give all these good antibacteria back, there's a chance we could give a bacteria that's bad back, or a virus like norovirus back that wasn't able to be found before we gave it to the patient. So while this is something we're interested in trying as a way to regrow the gut microbiome, then we need to be very cautious about this plan. So again, GVHD prevention is important. The main take-home point here is post-transplant Cytoxan, which we've already talked about, tacrolimus, and CellCept are other medications we use to help prevent graft-versus-host disease. We can also change the cells we give back to the patients. So when we collect cells from the donor, it'll have stem cells and B cells and T cells, and we can remove all of the T cells from the donor's blood after we take it out and give it to the patient. When we remove all the T cells, people don't have any graft-versus-host disease at all. But if we remove all the T cells, they also have an increased risk of relapse because there's no T cells there to kill the cancer or the leukemia. What we're looking at now is removing the T cells, separating them into the good T cells and the bad T cells, and then giving T cells back over time to rebuild the immune system. There's another medication that's been FDA approved called Abatacept. It works on slowing down T cell responses. In the first 60 days of giving Abatacept, there's very low, 1 to 5% risk of acute GVHD, but right now it has a kind of a limited scope. Other ways for prevention, Ruxolitinib or Jakafi was the first medication ever approved by the FDA for treating acute GVHD. So now it's in early studies for preventing acute and chronic graft-versus-host disease, where in some of the studies, less than 5% of people developed chronic graft-versus-host disease. Vedolizumab is another IV medication. It's completed its clinical trial. This medication is approved for ulcerative colitis. So you can see where it may have a role in preventing or treating graft-versus-host disease. The data looks promising, but we're waiting FDA approval. I did have a patient recently with ulcerative colitis that we continued his vedolizumab through the entire transplant, and he did very well with no acute or chronic graft-versus-host disease. You can't make too many judgments on one patient. That's what the clinical trial is for. How do we treat acute graft-versus-host disease? The first-line therapy is with high-dose steroids. All of these come with lots of side effects, which we'll talk about in a minute. High-dose steroids, though, are the background. Up to 2 milligrams of steroids a day. That would be, for most people, 120 to 200 milligrams of steroids, which come with some side effects, but also come with the best and fastest responses. If people aren't responding to steroids in 3 to 7 days, we have the first approved FDA medication for the treatment of acute GVHD, which is Ruxolitinib or Jakafi. This is a pill that you would take twice a day, and we've seen big improvements in 28-day responses and 6-month responses for acute GVHD, as well as improved survival. This is a key component of treating people with acute graft-versus-host disease. The next therapy is extracorporeal photopheresis, or ECP. So this is when we take the patient with graft-versus-host disease blood out of their body, run it through a machine with a special light that kills the T cells that cause graft-versus-host disease, and then returns all the rest of the blood back to the patient. This is one of the ways that we use to help bring the steroid dose down faster to eliminate some of the side effects from the steroids. Budesonide is an oral steroid. It's a topical steroid that coats the stomach. It doesn't really get absorbed into the bloodstream. Mesenchymal stem cells are approved for the treatment of acute graft-versus-host disease of the gut for children. And mesenchymal stem cells are in the bone marrow. These are essential cells to help the stem cells do all the things they need to do, make the red blood cells, white blood cells, and platelets, and they provide support. But they also have a relationship with the T cells and can slow down the active T cell response. This has minimal side effects. And since there are limited options, it's always reasonable to consider clinical trials. So what are the side effects of these treatments? High-dose steroids come with the most side effects: infections, increased blood sugars, diabetes, and people need to be on insulin. High-dose steroids cause weakness in the legs, especially the thighs, the hips, and the shoulders, cataracts over time, and bone damage. Some people have damage to their hips and months or years later may need hip replacement surgery. Ruxolitinib or Jakafi can cause low blood counts and increase the risk of infection. The main risk of photopheresis is very minimal, is accessing the port. Or a line, you need to have like a dialysis catheter to do this procedure, and anytime you access a line is a risk of infection, but it's a minimal risk considering we're accessing these lines anyway. Mesenchymal stem cells really have no side effects. There's a potential of a mild infusion reaction that's mostly probably from the medicine we use to help freeze the cells. And then supportive care. This is critical. So nutrition is first for GVHD of the gut. We always prefer to do oral nutrition, but if people are having 2 liters of diarrhea a day, the gut just needs to rest. If you keep putting food into the gut, sandwiches, baked fish and things like that, the gut won't be able to heal because the lining of the colon doesn't ever get to heal. So a lot of these people are on IV nutrition, which is adequate but is not as good as oral nutrition. Risk of infection. Almost all of the treatments we use increase people's risk for infection. So we have to be on antiviral medications, antibacterial and antifungal medications to prevent infection. We monitor for infections on a regular basis. Other supportive care includes physical therapy. We talked about the muscle weakness from prednisone. So we have physical therapists that come see the patient. People may be in the hospital for a long period of time. People with grade 4 GVHD could be in the hospital somewhere between 4 and 12 weeks. If they do well and recover quickly from their acute GVHD, this may mean they need inpatient rehab or other resources after they get out of the hospital. People that have had acute graft-versus-host disease, they have an increased risk of chronic GVHD. So we need to pay attention on how we back off on the immune suppression to treat graft-versus-host disease. In summary, on this slide, I've highlighted the things I want you to remember. So in summary, allogeneic stem cell transplant remains the only curative option for many blood cancers, but it comes with risks. One of those risks is acute graft-versus-host disease. Acute GVHD is measured by a red rash, diarrhea, and liver damage. Acute GVHD risks are influenced by many factors. One is factors of the donor, HLA, maybe age of the patient receiving the transplant is a risk factor for acute graft-versus-host disease. The choice of the chemotherapy, the choice of prevention, post-transplant Cytoxan. Treatment for graft-versus-host disease. Jakafi is the first approved medication for GVHD. It's been critical since 2019 to improve outcomes, even for the grade 3 and 4 most severe forms. Mesenchymal stem cells are also approved, and ongoing clinical trials with new hope for preventing and treating graft-versus-host disease. I'd like to thank BMT Infonet for inviting me to this program. It's been a critical resource for our patients and our families. And I'd also like to thank all of the patients and my families who I interact with on every day, and we learn from each other every day. There's always something new to learn. And I'll be glad to take any of your questions.
Thank you, Dr. Clark. We'll now begin the Q&A session. If you have a question for Dr. Clark, please use the Ask a Question box on the left side of your screen to submit your question. We will answer as many questions as possible. The first question, once you get GVHD under control, what are the odds of it coming back?
Right, so once it's under control, the critical part is tapering the immune suppression over time. The chance of it coming back is hard to say a number for because it varies for each person, but it's significant. I would probably say 30 to 50%. And it may come back not as acute GVHD, but it could come back as chronic graft-versus-host disease. So it'd be a different form. So it's not unusual for someone to have acute graft-versus-host disease of the gut in the first 100 days. That all goes away. We taper the immune suppression. And then when we're tapering the immune suppression, they have dry eyes and a dry mouth. And then we treat that, and that goes away. And then they have GVHD of the lungs. And then that goes away. And then they have graft-versus-host disease of the skin.
On slide 23, you mentioned a potato starch for butyrate. Do you recommend a butyrate supplement for the prevention of acute or chronic GVHD in the GI?
For now, only on a clinical trial would be my answer to that. Or if you talk to your doctor about doing that. We are not giving patients butyrate off of clinical trial. We don't have a clinical trial open at VCU for that. We are not giving people butyrate.
This patient is 3 years in remission, but still experiencing chronic GVHD and also C. diff for more than about 4 times. Is this normal after transplant?
It's hard to find what normal after transplant is. I think a lot of different things can be normal, and I certainly have seen patients in this situation. So keeping in close touch with your transplant infectious disease doctors for the C. diff and your local transplant doctors, and maybe GI doctors would be, key to helping minimize those symptoms.
Is acid reflux associated with the use of prednisone?
Yes, we put people on acid prevention while they're on steroids. So heartburn, gastric reflux, gastric ulcers are all things that can be related to use of high-dose steroids.
What are your thoughts
talk to your local doctor about your specific risks, please.
What are your thoughts on a probiotic strategy to prevent the recurrence of C. diff? What do you think about Fluorostor?
I'm not familiar with Fluorostor. If there is a probiotic, so that we're talking about living bacteria, it's very important to know what immune suppression you're on. So bring the bottle of the probiotics to your local doctor and discuss it with him and the pharmacist to see if it would be safe for you to do.
Would individuals with GI GVHD follow a plant-based diet?
I usually recommend a healthy, well-balanced diet, which would mostly be plants, vegetables, and fruit, grains, and so on, with some meats, and less fats and sugars. A good diet to follow would be something similar to like a Mediterranean diet.
This person is starting to have some GI issues 3 years after transplant. Should they see a regular GI specialist, or should they see a GVHD GI specialist first?
I would usually recommend they start with their transplant physician, and they can maybe help navigate the best path for getting into the right resources in the medical system more efficiently.
This person has a daughter who had a stem cell transplant 6 years ago, and she has pain across her stomach, in the middle, in her chest. She had a gallbladder removed, and that helped, but she said that she's heard the vagus vein is impacted by the stem cell transplant. Does that vein impact the GI functions?
Maybe the vagus nerve, maybe something I'd be more familiar with.
Vagus nerve. Yeah, vagus nerve.
Okay. That sounds like a very complicated situation. I'm sorry that your daughter is suffering. I think that one is hard to answer over the phone, and please continue to follow up with your local doctors and ask them those questions. I think that's a very unique, specific situation. I'm not sure I can comment on that without knowing more.
Does eating sugar cause inflammation in people with GI GVHD?
I think, eating, excessive amounts of sugar does cause inflammation, especially if your blood sugars are elevated like they would be for diabetics eating too much sugar. I think these foods are limited when people have severe acute GVHD, right? But, part of the IV nutrition does include dextrose, which is sugar. So I think it depends on the situation that you're in. It's hard for me to recommend that, cancer survivors and transplant survivors shouldn't be able to have a chocolate chip cookie every once in a while. But the sugar should be, in moderation.
Does GVHD eventually burn itself out? What are some signs I can look for?
So when we're talking about GVHD burning itself out, people are mostly talking about chronic graft-versus-host disease in that scenario. It depends on the severity and the length of time that you've had it. So sometimes it does get less over time. I would say people that have severe chronic graft-versus-host disease, about 30 to 40% of them will not need any more immune suppression 2 to 3 years after they start their treatment for chronic graft-versus-host disease. Acute GVHD can be put into remission. I think we don't usually talk about it as burning itself out because the story is not finished at the end of acute GVHD, as there may be a risk of chronic GVHD in the future, right? So we're looking for, talk about acute GVHD as going into remission, and then if people have severe chronic GVHD, we do wait for it to go in remission. That would be the burning itself out. That would be in 30 to 40% of people.
Do you have any recommendations for the management of acid reflux with chronic GI GVHD? And is there any way to prevent it from returning?
For chronic GVHD of the gut, we usually have our people on proton pump inhibitors. So that would be medications like Prilosec or Nexium or Protonix. Sometimes we have a few people on Protonix and on Pepcid at the same time. If you have chronic acid reflux, it may be worth having an EGD where someone takes a camera and looks into the stomach and esophagus to look for damage there. Some people can have Barrett's esophagus, And cancer survivors are at increased risk of other cancers, so in the appropriate setting, cancer screening would be warranted. So talk to your transplant doctor about your specific risk of gastric reflux, how to best treat it, are there better options, and then is there a reason for a referral to a gastrointestinal specialist?
What are some of the differences to tell if you've had chronic versus acute GI-GVHD?
Mm-hmm. Yeah, so acute GVHD is kind of easier to diagnose because it would be just a red rash, an elevation in the bilirubin, and diarrhea or persistent nausea with a weight loss of more than 10%. Chronic GVHD is more difficult, and sometimes you can have both chronic and acute GVHD at the same time. Chronic GVHD would be more like a dry skin rash or dry mouth and dry eyes. People can have tight skin, so maybe not being able to move all of their joints to the full extent.
This person has random flare-ups in their gut that last about a week, causing pain, indigestion, nausea, and fatigue. Is that pattern normal?
Well, a lot of things can be normal after transplant. I think it depends on the time since they've been on transplant and what medications they're on as to what the cause of that would be. I certainly see a lot of those symptoms in the first 100 days as people are recovering from their chemotherapy and are having difficulty time advancing their diet. But it really depends on a lot of circumstances for those symptoms. So I would discuss those symptoms with their doctor to see if there's a pattern to it or other things that need to be investigated.
What are some suggestions for a spouse caring for somebody who feels nauseous quite a bit due to GI-GVHD?
Yeah, that's really, I know that has a lot of stress for all of our people that provide support for my patients and on multiple levels. But nutrition is one of them. Yeah, so things you can do to support them is just to be, patient. We want to make sure they have enough calories, so kind of keeping track of what they're eating. It's very difficult for humans to count their calories without actually getting a calculator out or an app out to count their calories, to make sure they're getting enough nutrition. Focus on the foods that work well for them. If there's a food that's not working for them, whatever it may be, then, okay, come up with a different plan. You can always use supplements to help with nutrition as well, but if they don't like Ensure, then try a different brand or a different product. And then some centers have nutritionists that can help give you advice about nutrition when you come into clinic.
Are there certain foods that you should avoid with GI-GVHD?
It depends on the amount of GI-GVHD you have. If you have like a grade 1 upper GI-GVHD where you have persistent nausea and don't feel like eating, then you can eat mostly what you want as long as the food is washed and cooked appropriately. But if a food doesn't agree with you, then avoid that food for a few weeks or a month or two, and then try it again. I try not to limit food very much, but it's really up to how the person's experience with that food is, and everyone's journey is different. So it's a little bit of trial and error about what works best for you.
Okay, this will be our last question for the afternoon. This patient's tacrolimus has tapered off without signs of GVHD. Is the probability of chronic GVHD, will that decrease as time goes on?
The probability of chronic GVHD should decrease as time goes on. The average onset is a wide variety, but usually between 120 and 300 days after transplant. Theoretically, the risk could be lifelong, but don't take that as an overstatement. The risk does go down with time. So like if you had a rash 8 years after your transplant, I would be skeptical that that was graft-versus-host disease unless someone really proved it to me and with a biopsy or something like that. So yes, it should decrease over time. Your immune system will get stronger every day that you live, and your new immune system will get to know your body every day that you live, and the risk of GVHD should continue to decrease. But yeah.
Well, on behalf of BNT InfoNet and our partners, I'd like to thank Dr. Clark for a very helpful presentation. And thank you, the audience, for your excellent questions. Please contact BNT InfoNet if we can help you in any way, and enjoy the rest of the symposium today.